Welcome to this episode of CRST the podcast. In today's program, Professor Richard Harrad from the University of Bristol in the UK leads a discussion on the management of amblyopia, focusing on new technologies that could change the way that we approach this common condition. In this episode, we will discuss the strategies currently used to manage amblyopia and talk about the use of dichoptic therapy as an innovative digital solution. We'll cover the potential benefits of dichoptic therapy as well as the challenges associated with its use.
Welcome to this podcast. My name is Richard Harrad. I'm an ophthalmologist in Bristol in England. And today I'm joined by Ben Thompson and Anne Webber, and we'll be discussing dichoptic therapy, a new approach to the management of amblyopia. Anne, can you please tell me a bit about your background and your interest in dichoptic therapy?
Yes, thank you, Dr. Harrad. Yes, my name is Anne Webber. I'm a paediatric optometrist in Brisbane, Australia. As well as holding a private practice appointment, I have an appointment at the Queensland Children's Hospital and a associate professor appointment at the Queensland University of Technology. So I have a clinical interest in amblyopia because 80% of my practice would be working with children, but I also have a strong clinical research interest in amblyopia, particularly the functional impacts of amblyopia, so how it affects children and their families and how it affects function and performance. And I have a particular interest in understanding the underlying mechanisms of amblyopia and how we can best achieve treatments.
Thank you. And Ben, can you please tell me a bit about your background and your interest in dichoptic therapy?
Absolutely. I'm a professor in the School of Optometry and Vision Science at the University of Waterloo in Canada. My background is actually in experimental psychology and neuroscience, and my primary research interest is the development and neuroplasticity of the human visual system. In terms of dichoptic therapy, I've been involved in this field for a number of years now. At the start of my career as a postdoctoral fellow, I was involved in developing dichoptic therapy at McGill University, also in Canada. And it's been a theme throughout my research to this point. And most recently, I've led a randomized clinical trial of dichoptic therapy that we reported last year.
Thank you very much. Anne, can you please outline the current therapeutic options for treatment of amblyopia?
Amblyopia, as we know, is abnormal vision, is poor vision from abnormal vision development early in life. So, treatment generally is been about identifying what the underlying amblyogenic feature may be. So that may be uncorrected refractive error, and treating that underlying cause first, and then generally some sort of active program to promote the re-engagement of development of the visual system. And that may be by occlusion, so penalisation of the dominant eye to promote vision development of the previously disused visual pathway. And that may be penalisation by putting a patch, an occlusive patch over the child's eye or over the child's glasses, or it may be penalisation with atropine so that creates a blur into the dominant eye, again, with the idea that would then promote the re-establishment or sort of reigniting of development of the previously neglected visual pathway. So these are monocular therapies sort of based upon the premise that amblyopia very much was a visual acuity deficit. So it kind of wasn't necessarily considering perhaps the chicken and egg question of, what was amblyopia? Was it poor visual acuity, and then was poor binocular perception the result of poor visual acuity in one eye? Or could it be the other way around? So could the poor binocular fusion be the actual initiator of the eventual retardant of visual acuity? So, current strategies tend to be, have traditionally been monocularly based, but based upon more recent research that's shown us a lot about the visual cortex and plasticity, more treatments are coming into this dichoptic area.
Okay, and thanks. That's helpful outline, can you tell us perhaps a little bit about the weaknesses of the conventional treatment with occlusion and penalization, where, you know, clearly it's not ideal, otherwise we wouldn't be looking around for other better therapeutic options.
Yeah, I think well, one of the problems is that there is a significant proportion of children that even if you treat them by these methods, that still carry some sort of residual visual acuity deficit, even with best efforts. There's also a difficulty of compliance sometimes with these programs, and you know, that there was concern that patching for children may have adverse psychological or adverse psychosocial impacts on the children or family, and so whether there could be treatments that were less harmful, potentially harmful to the child was something that was considered. But also there have been limitations to the age at which you will get good visual acuity recovery outcomes as well. So sort of traditionally we've had the perception, had the clinical belief that you will get good success with the traditional treatments up to about the age of 8. But whether there are new treatments or alternative treatments that could re-engage the more mature visual system. So with sort of compliance, you know, significant proportion that weren't getting good recovery. Even those that recover, there was a significant proportion that then regress. And then the difficulty of treating the more mature visual pathway.
Okay, that's very helpful. Thanks. So, Ben, would you like to perhaps outline what dichoptic therapy amounts to for the listeners?
Absolutely. I think Anne's coverage there of the current treatments was excellent. And just to build upon that, and to link into dichoptic therapy, one of the issues with current treatments is they really just focus on vision in the amblyopia on its own, rather than trying to re-engage binocular vision, which allows for 3D depth perception, which I guess is one of the most functionally relevant losses that people with amblyopia experience. And the idea behind dichoptic therapy is to really target binocular vision as the primary therapeutic component of the treatment. So just to give you a bit of a background to the underlying idea, one of the, or I should say really, a really striking phenomena in amblyopia is that when people who have amblyopia have both eyes open, information from the amblyopic eye tends to be suppressed from conscious awareness. And in really strong cases of suppression, the patient can have both eyes open and they're really only consciously perceiving through their good eye, through their fellow eye. So somewhere in the brain, information from the amblyopic eye is shut down. In a series of experiments leading up to the somewhat serendipitous discovery of dichoptic, or the principles of dichoptic therapy, a series of experiments were conducted to address whether people who have amblyopia still have the connections in their brain that are required to support binocular vision. And the way that this was done was to vary the visibility of the images seen by the two eyes to see if there could be a point where the two eyes began to work together, which would be a demonstration of the fact that those brain mechanisms were still in place. And the way the images were varied is that very high contrast or clearly visible images were shown to the amblyopic eye, and much lower contrast or harder to see images were shown to the fellow eye. And if you get that contrast difference between the two eyes right, it was found, then the brain can use those images together in people who have amblyopia. So this demonstrated that the brain was able to combine information from the two eyes. What happened in those studies, and I guess I can tell you a bit of my experience because I was involved in them. We had participants coming into the lab and we were measuring what we called this balance point contrast, which is the difference between the two eyes that's required for binocular vision to take place. And we found that the more we measured that, the less difference that they required between their two eyes. And some participants reported spontaneous improvements in their visual acuity and their binocular vision. And it seemed that just by repeatedly exposing people to images they could combine between their two eyes led to an improvement. Unexpected, it just started off as a study looking at binocular vision. So on the basis of this, the team that I was part of, we started training people on some of these tasks, and we found improvements in their acuity and in stereo. And perhaps most strikingly, these were adults in their 40s and 50s. And as Anne quite rightly said, There's a concept in amblyopia therapy whereby the brain has a high level of plasticity during development and can relearn how to use an amblyopic eye. But in adulthood, that plasticity is thought to be lost. And yet we found improvements in these adult patients. And so that really was the basis for the dichoptic therapy. Just to summarize, the idea is that you show much more visible images to the amblyopic eye than to the fellow eye, and you find a point at which the brain can combine them. And then you repeatedly expose people to images that allow for binocular vision. In terms of the mechanisms for how it works, there are a number of possible ways. One is that it addresses an active suppression of the amblyopic eye. So the brain is acting to shut down that information. And by using this contrast imbalance, we're able to overcome that suppression and gradually weaken it over time. Another possibility is that there is no active suppression. It's just that the amblyopic eye signal is very weak. And by having the contrast imbalance between the two eyes, we're activating binocular cells in the brain and giving them correlated input from the two eyes. And over time, those binocular cells strengthen, the synaptic connection strengthen to allow recovery of vision in the amblyoptic eye. And even recently, and I think Anne will probably want to comment on this as well, there's really exciting new work coming out suggesting that there are differences in attention associated with amblyopia, how the brain actually allocates attentional resources to the amblyoptic eye and to the fellow eye. We did a study quite recently demonstrating that when the two eyes have images that can be seen binocularly, the brain cannot allocate attention to the amblyoptic eye as effectively as a fellow eye. And so dichoptic therapy might be working through that kind of pathway as well. I know, Anne, that you have some interest in this area too.
Yeah, that's right. I mean, I think we've thought of the deficits with amblyopia as being, a monocular visual acuity, and then we've sort of gone beyond that and thought that, well, no, it's actually the binocular combination, and it's within the striate cortex, and that's sort of the classic studies of Hubel and Wiesel that have shown us that physiologically. We know that there's other psychophysical deficits such as poorer positional sense, so your hyperacuity deficits and things. But we're now starting to explore what the higher level executive function deficits may be. So what's happening in these sort of brain networks that are beyond our visual pathway, and are they altered as well in amblyopia? And we've recently conducted a study looking at a test called useful field of view, where you have selected and divided attention tasks, and found that amblyopic children are poorer than control children on that activity, and that the sort of the difference between the two groups was greater as the task became more complex. And we also had the kids do a task which was a trail making test where they had to link and solve some puzzles. And again, those activities were poorer or slower for the amblyopic children to complete than the control children. And again, the difference between the two groups was greater as the tasks became more complex. So it sort of points to this sort of higher level executive function, potentially attentional deficits that may also be there. So, beyond what we've been thinking about is the visual decrement of amblyopia. And in these novel and new emerging treatments, so we've got dichoptic therapy, but we've also had other studies that have looked at things like action game playing or perceptual learning, all of which that engage and drive attention. And so there's starting to be some really interesting studies trying to look then, what is it there that maybe these activities, these dichoptic activities that also require the kids or the participants to attend and solve puzzles, maybe that's switching on some high level executive function, substrate that then is then passing down to binocular and then passing down to visual acuity rather than top up. So, this is all quite speculative, of course, but, I think adds to what's coming. Yeah.
So we got top down, bottom up. I'm interested in the idea that the binocular cells or the binocular system has really been ignored in conventional treatment. It interests me that where you have no binocular function whatsoever, as you do with congenital esotropes who end up alternating with no amblyopia and no binocular function, it seems to me no coincidence that they have no binocular function, but that in a sense is what has preserved their visual acuity. The binocular cells are the battleground for the control of visual acuity in those children who go on to develop amblyopia. And since that is the battleground, that should also be an area that is part of the treatment. We need to be treating binocular function in order to get the best results for our amblyopia treatment. And I think the alternators with no amblyopia, those patients are an indicator of, as it were, the sort of extreme example of what happens if you don't have any binocular interactions at all. And that somehow preserves their vision. I wonder what you think of that as an idea, Ben. Is that?
Yeah, but I think that's right. I was thinking of an experiment we tried some years ago now to see if we could measure these binocular interactions in people who had alternating esotropia in the way that you describe. And we found that we had to have really, really extreme contrast differences between the two eyes for them to be able to have any kind of simultaneous perception, and some of them couldn't. So I think, you know, your idea fits with the data that we have. Whereas in amblyopia, you know, we can get the two eyes to be used simultaneously with a moderate contrast offset for most people.
We also conducted some studies that were looking at the relative contribution of monocular acuity loss versus this contrast decrement loss to stereopsis. So if we think of stereopsis as kind of the pinnacle of the functional triangle of binocular vision, in these patients that have got equal acuity but have got a very high contrast imbalance, they were the ones that had the most degraded stereo acuity. So we did have a look both within patients who'd had a history of amblyogenic factor interrupting their normal vision development, but we also looked in a model of participants with normal binocular vision development, but then we introduced a visual acuity decrement with a filter. And so they didn't have the acuity loss. And it was really very striking that the sort of the level of the depth of suppression was what was driving the loss of binocular stereoscopic ability, and it wasn't the visual acuity that was the gate.
Thank you. So moving on, perhaps, Ben, could you describe how this therapy actually works with the iPad and glasses, etc.?
Absolutely. So there's two ways that binocular therapy has been deployed. So one is called dichoptic therapy has been deployed. One is called active therapy. So this is typically in the form of video games where the elements of the video game are split between the two eyes with a contrast difference favoring the amblyopic eye. And then the participant plays the game. Typically, that contrast difference would be tailored to that particular person's level of suppression. The crucial element here is that neither eye gets all of the information from the game that's required to play. So the only way the person can successfully play is to combine information between the two eyes. The original game that we designed was a version of the video game Tetris. As you can imagine, that was quite an easy one to do because there were blocks falling down the screen, blocks at the bottom of the screen that we could easily split between the two eyes. The downside, as we found out, and as I expect we'll discuss later, was that it wasn't a particularly engaging game over a period of time. And so more recently, much more interesting versions of video games have been developed that use the same principle, where characters will be in one eye, backgrounds in the other, and so forth. So this is the active technique. The passive technique is, rather than having people play a video game, they watch a cartoon or a movie, and elements of that cartoon or movie are split between the two eyes. The most common way of doing that so far is to split each frame into a jigsaw puzzle, and some of the pieces are shown to one eye and some of the pieces are shown to the other eye. And so the brain has to complete the puzzle in order to be able to watch the movie properly. The vast majority of research has been conducted using the active technique, but passive technique studies are coming out. They're looking promising. And of course, they're much better suited for younger children who aren't yet able to engage fully with video games. So the idea is you would select a dichoptic treatment subtype that was most suitable for the patient's abilities and their age.
Excellent. And What about the clinical trials that have been carried out using this approach? What kind of results have we been getting?
They've been mixed at best. So the initial studies that came out of the Retina Foundation of the Southwest were very promising. So they reported larger improvements in acuity in children who were treated with the dichoptic treatment versus patching. Other studies that have been done by the Pediatric Eye Disease Investigator Group have either shown approximately the same effect as patching or no effect of dichoptic treatment. And the clinical trial that I led, which I expected would show the same sort of results we'd found in the lab, showed no difference from placebo in a randomized clinical trial. So really a broad range of different results in the clinical trial literature at the moment.
So what have we learned from these trials that could help us design better therapy in the future?
My view at the moment is the underlying issue is how people engage with the dichoptic treatment in the home. So when we were first developing this technique, everything was done in the lab. People were closely monitored as they were taking part in the treatment, and the results were very promising. Now, that being said, they were initial proof of concept experiments, so they weren't as well controlled as a randomized trial. So there would have been sources of bias in those experiments, but the participants were well monitored. When we have come to the clinical trials, we've moved from those laboratory conditions into the home environment. And what I think has happened is that people just engage with the treatment very, very differently. So I can give you an example. For the clinical trial that I ran, we found low adherence with the treatment. Now, we did use the Tetris video game, which, as I've mentioned before, was perhaps not the best choice because it does get pretty dull pretty fast. And so people weren't so keen at playing it over a long period of time. And we saw that in the adherence data. We've more recently done a very detailed analysis of those data. And I should say, one very nice thing about using electronic devices for treatment is they record a lot of information that you can come back and check out later as to the time of day people played, how long they played it for, what kind of scores they got on the game. We found it in the trial that I led that people we asked them to play for at least an hour a day. They tended to play for about 20 minutes a day if they played at all. The blocks of play were short, and people paused the game on a median time of every 4 minutes. So we included a pause button in case people needed a break. Clearly, that wasn't the best thing to have done because they were disengaging from the treatment even during those treatment periods. And I think, if you imagine doing these kind of games at home, we had adult participants and we had children participants as well. I expect people were going about their daily lives, watching TV, perhaps their favorite show was on, or their siblings were watching TV in the corner, or their children were fighting, or they were trying to do something else. And so you play the game for a period of time, you're looking up, you pause it. So that engagement in the home is very, very different to the engagement in the laboratory. And I think based on the evidence that we have from human studies and from animal models as well now, I think the underlying principles of dichoptic therapy are well supported. It's the implementation in the home that is the really difficult component of it. And I think that's where we need some serious work to consider what might be the best way to do that. So I think that's where we stand.
Okay, thanks. Anne, any comments on what Ben has said?
No, I mean, I would concur. So I did run a trial looking at that employed the Tetris program because a lot of my research interest was in the impact of amblyopia on fine motor skills. And one of the questions that comes out of that is whether the decrement in fine motor skills that is now well recognised in amblyopes, whether if you treated the amblyopia, whether fine motor skills would improve. I was aware of the dichoptic training and employed that as the treatment in my trial, more because I wanted a treatment that had shown improvements in a short period of time, so in a 2-week period. So I wanted to know that if there was any improvement in fine motor skills, that it wasn't because the children had matured 6 months or 12 months, which is how long patching or atropine therapy will often go for, so that we could really know whether or not improvements were from treating the amblyopia and not from just natural improvement with age and maturation of the child. So in that study where I did use the Tetris, compliance rates were reported to be quite good, and we had levels of improvement in acuity that were at around about the 1.5 lines. Now, if you look across all of the, as I say, these sort of novel and emerging, your perceptual learning, your action video game, and the dichoptic, so meta-analyses that have compared across these are generally finding that it's about a 1.5 line improvement. So I think that's one of our other challenges, is that patching and atropine in the ideal clinical group, so our kids who are aged somewhere between 3 and 8 or 9, the number of lines improvement is much better. So I think that's also a little bit of a disappointment in the clinical group, is that there just isn't those sort of dramatic 2 to 3 to 4 lines improvement in acuity that we may get in a young child who we're sort of patching straight away. But there's still too many unknowns. There's too many variables that are influencing, the compliance to the task. But what my patients were reporting to me was, do you know what, could I go back to patching, because I could just put a patch on and I can watch any video game that I want, not just the one that you're serving up to me. So it kind of ended up flipping around. We thought that they would be wrapped in having their own little iPod and wrapped with doing something that was more technology driven. But in fact, they just wanted that choice. Kids are now far more technologically sophisticated than they were, even when all these studies started 10, 15 years ago then, that it's we're really, racing to keep their engagement. But I do truly believe that something, as you pointed out, Richard, in that binocular battlefield that is, makes this worth pursuing. We know the science makes sense. So it's how do we really combine it down and serve it in a way that is engaging and is also accessible, because, there's cost to technology and equipment and things like that. So we've been able to provide them in trials, but then how do we actually get those things into the hands of patients? So yeah, I think there's still work to do. Okay,
I'm getting a strong message here that we need to have games that are engaging, that the participants, the patients will look forward to playing, and get up early in the morning and rush off and grab their iPad and put their red and green glasses on and get going before school. If we can achieve that, the results that certainly from some of the studies suggest that the amount of time that needs to be spent doing iPad games in this dichoptic therapy is much less time than you would spend having a patch on your eye, with the inevitable consequence of reducing your visual function. I mean, if you've got an amblyopic eye that has very poor vision, and you having to spend 6 hours of the day with your good eye wearing an eye patch, life can be really quite difficult. So I think that the advantages of having 1 or 2 hours of a day of treatment using the video game is a considerable, because it means that can be done at home. It doesn't affect schoolwork. If we can just get the right games with the right that engage our patient groups efficiently, then I think there's huge scope for bringing about rapid improvements in vision.
Yeah, and I think it's not only just the time that you're spending each day, but it's actually the whole duration of the treatment. I think that's what was very exciting initially, was that it was like, you're getting those results in a lab in just 2 weeks. Whereas, as I say, that the patching program or your atropine program tends to be, a 6-month program. And high variability between clinicians in the amount of patching that they do. And we know there are some dose response curves that have come out of the monitored occlusion treatment studies that suggest that, it was 100, 200 hours of cumulative patching is kind of where things plateau. We don't know how long you have to do the dichoptic treatment for. So it may be that it is an hour a day for a month is where you're going to plateau. Well, that's maybe that's going to be something that is achievable for a family versus battling with the child to get your 2 hours or 4 hours a day of patching for how long? 3 months, 6 months, a year? So I think there's that element of it as well, the whole duration of the treatment program. It'd be wonderful if it was relatively short for the families.
Okay, I'd just like to ask a particular question about the kind of patients with amblyopia who are suitable for this treatment. My impression is that if you've got a strabismus of more than about sort of 8 prism diopters, so in other words, a large convergent or divergent squint, you can't really use this treatment. Am I right in thinking that? Because if that's true, that excludes the majority of children with amblyopia, because it means you can only really treat those with a small microtropia or anisometropic amblyopia.
Richard, I think that's a great point, and you're right that in many of the trials, anybody with a substantial strabismus has been excluded, and the primary reason is that the treatment devices allow you to offset the relative images of the two eyes by a certain number of pixels on the screen, but the screens are quite small. So what I mean by that is if the two eyes are misaligned, you can misalign the images on the screen so that they would be fusible by the participant, but only within a limited range. In the study that I did, we used an iPod Touch, which obviously is a very small screen. The pedic studies have used iPads, and again, they're limited. It remains an open question is if people use different types of technologies, whether people with larger strabismus angles could be treatable using this technique. There are groups that are looking at head-mounted displays and so forth for delivering the treatment that may provide more flexibility. In our initial lab studies, we did have people with larger strabismus angles, and they were corrected prismatically, and we had a mirror stereoscope, that, like a formal lab setup, I guess, that gave us much more flexibility. So you're right, I think it's an open question, but certainly with the current technology, there are limitations.
Yes, so I'm pleased to hear that there are options, as you say, with head-mounted displays or including prisms. One thing occurs to me is that if this technique progresses and it's more widely used, it would be a reason to actually carry out surgery to correct the strabismus prior to amblyopia treatment, rather than doing what we do at the moment, which is to say, well, you can have your surgery once we've managed to get your vision sufficiently improved. So we tend at the moment to treat amblyopia first and then operate, but it might be a reason to operate and then treat the amblyopia if indeed we are starting to roll out this treatment more widely.
That's really interesting. I hadn't realized that was the sequence.
Yeah, well, that's a good, because one of the worries is that the parents will say, oh, my child's got straight eyes now, I've got nothing to worry about, and abandon amblyopia treatment because their principal concern is what's noticeable to them, which is the visible strabismus that the child has, rather than their visual deficit. So we're sort of making assumptions and perhaps manipulating patients slightly and rewarding good amblyopia therapy with the promise of an operation. But that could all change, in the light of these new techniques that are becoming available. So we're nearing the end of this discussion. Anne, is there anything you would like to add?
Well, look, I just do think it's exciting times. I think it's we do know that the traditional treatments have got drawbacks. The impact on family and children, and the number of families for whom it just becomes too difficult to battle, so they abandon doing anything, and so that you end up with something that really is a lifelong burden. This is a vision loss that's right at the start of somebody's functional life. So if we can turn this around and restore good vision, not only good monocular vision but good binocularity, so they've got that extra sort of driver to reach their potential, I think it's exciting times.
Thank you very much. So that's all we have time for today. I'd like to thank Ben Thompson and Anne Webber for their contribution. And I hope that you have found this an interesting discussion. Thank you very much.